One, two. I think you've got a quorum of your members here, and I've got my full subcommittee. So if you're ready, we can have.
Yeah, I have everybody but Delegate Valentino Smith, who is in judiciary on a bill hearing right now.
Okay, very good. So if everyone's ready, we can start the live stream.
Absolutely.
Are we all set, Philip?
We are good to go.
Fantastic. Thanks, Nick. Well, good afternoon, everyone. It is February 4th. I'm Melanie Griffith, the chair of the Subcommittee on Health and Human Services under Budget and Tax. And we are here today with the House Appropriations Subcommittee on Health and Social Services for a budget hearing on the Maryland Department of Health. We're going to have an overview by our budget analyst, Ann Wagner, in just a moment, but I certainly want to thank all of the members and our phenomenal staff for being here. We have an incredible team of analysts who are here, and just certainly want to welcome. Also, we have a new member to our subcommittee, Senator Young, and so Mr. Acting Secretary, if you haven't met him, wanted to make sure you and your team know that he's here, and I think you know the rest of the subcommittee. With that, I will turn it over to the House Chair, Chair Resnick, to see if you have any opening remarks. It's good to see you.
Good to see you as well. I am ready to go. So we're good.
Fantastic. So we're going to proceed. And for those of you that are watching, we may have members that have to step out for a moment or two or go off camera. We are currently having bill hearings in our other standing committees. So if members have to leave, just know that they are doing the state's business and will join us back again when they can. So with that, we will turn it over to our analyst, Ann Wagner, to talk us through the Maryland Department of Health overview.
Great, thank you, Madam Chair. So I'll be sharing my screen to walk through the document with you all. Can you see that? Okay, great. And I'll be presenting along with Simon Powell and Andrew Garrison, also from Department of Legislative Services, to go through the department's budget this year. So starting off with the 5-year recent budget amounts for the department, you can see that in 2018 and 2019 actual spending, the department's budget was around $14 billion. And then in fiscal 20, you're starting to see the effects of the COVID-19 pandemic and the state's response showing up. This purple bar here is mostly reimbursable funds, and that's reimbursement from FEMA for COVID-related spending. And then this bar here is showing federal aid for the COVID-19 pandemic response. In 21 and 22, you're seeing this level of spending continue and actually increase slightly in fiscal 22. And whereas in 20, the growth was mostly in federal funds, you're seeing in 22, the growth is actually mostly in state general funds. And I'll note here that notably the fiscal 22 budget does not currently reflect any of the December stimulus package that was just recently passed. And we'll talk a little bit more about COVID federal funds in just a moment. To go over a few fiscal 21 actions, the governor is proposing a few deficiencies that would add about $267 million related to the COVID-19 pandemic in the current fiscal year 21. And there's also a proposal to add $87.3 million, and that's to reflect the governor's decision to accelerate the 4% mandated provider rate increase from the beginning of fiscal 22 to begin January 1st of this year. So that's why you're seeing that deficiency. I'll jump ahead to page 6. We're looking at the proposed budget change in the department, and the total budget in 22 increases by about $604 million. And I'll just go over a few of the major changes in the department. In terms of regular personnel, you're seeing an overall decrease of about $200 million. This is driven by a deficiency that added $220 million in federal funds in the department. And this is to reimburse other agencies for some of their public safety and public health salaries in the current fiscal year. And then that's not reflected in fiscal 2022. In terms of programmatic spending in behavioral health administration, this administration accounts for about $181 million of growth in 22. This is mostly due to increased enrollment projected in fiscal 22 and expanding services in next year. In terms of public health, the Prevention and Health Promotion Administration increases by about $97 million. This is one of the main exception showing actual COVID-19 federal expenses in fiscal 22. About $60 million of growth is for COVID-related expenses for lab services, contact tracing, and COVID surveillance. And then there's $24 million in federal funds budgeted for the state's contact tracing IT platform. So this is just one of the exceptions where you are seeing COVID federal funds added to fiscal 22. In the Developmental Disabilities Administration, this office accounts for about $73 million of that $600 million growth. And this is mostly in expansion to serve more people off of the waiting list and to expand services for people already in the community services program. In the Medicaid administration, you're seeing this driving the majority of the growth in fiscal 22. Overall, this accounts for $438 million of additional spending next year, and that is mostly due to enrollment and utilization projections, costing about $250 million more next year. With this chart, we're trying to describe the federal funds that have been authorized to the state and what we expect to run through the Department of Health's budget. On this column, this shows CARES Act and Families First Act authorizations that happened in the interim. And then this column shows the December stimulus. And again, just to repeat, this isn't shown in the budget, but we wanted to at least show an accounting of what has been announced and what we expect the department to receive from the federal government. The largest source of federal funds has been through an enhanced Medicaid match. This is about a 6% increase in what the federal government normally contributes to Medicaid spending. And so over fiscal 20 and 21, we expected the department to receive $935 million in additional federal match for Medicaid. And then most recently, the Biden administration announced that they were actually extending this to the end of calendar 2021. So because this will continue on into fiscal 22, this $935 million number is actually understated, and we expect federal attainment to be higher than this. And then the next largest source of federal funds is through FEMA reimbursements. This is mainly for PPE procurement and ventilator procurement in the state. That is estimated to give the state $818 million over fiscal 20 and 21. In terms of the coronavirus relief fund, about $684 million of it is expected to be spent on specifically health-related spending. The department does reflect other coronavirus relief funds that it uses to reimburse other state agencies for uses like rental assistance or support for higher education institutions. But at least for the purpose of this chart, we focused specifically on the health spending. And then looking at some of the funds that the state received from the CDC, overall, the department is expecting to receive about $555 million for testing and contact tracing, and then $71 million in vaccine distribution across the both December stimulus and the CARES Act and other federal stimulus passed over the interim. Down at this part of the chart, we wanted to note some of the other federal funding that is coming into the state, but wouldn't appear in the department's budget. This includes direct grants to healthcare providers. That amounts to about $2 billion. And then direct coronavirus relief fund grants to certain counties. The federal government provided direct grants to the 5 most populous counties in Maryland, and that accounts for $691 million more coming to the state. So then while we expect the state or the department to receive over $3 billion in federal aid, we wanted to note how that compares to the funding that's actually reflected in the budget as introduced. Again, this wouldn't include the December stimulus. And then there's also some CARES Act that isn't reflected, but of what is shown in the budget as of the introduction date, the 43% of the funding from federal funding for COVID response is 43% in that enhanced Medicaid match. and then 33% of that FEMA reimbursement for PPE procurements. Oh, I'm sorry, just one more note about the federal fund on for the COVID response. So that difference of about $1 billion in what has been announced but isn't reflected in the budget yet, this can be added in a couple different ways. The governor might choose to introduce a supplemental budget if before the end of the session, where that would add some of the federal funds and would provide some information on how the department has used some of these CARES Act funds. And the other option the governor has is to introduce or add this funding through the budget amendment process. And budget amendments were typically how the federal funds were added in fiscal 20, since a lot of the federal aid was passed after the session had adjourned. So that's just a note on how that difference of $1 billion could be added to the budget later on. So next up, Simon will discuss the Medicaid enrollment trends recently.
Thanks, Anne. We just thought it'd be useful to see the growth in enrollment. Anne's pointed out the extent to which Medicaid spending is driving the total budget change. The top chart here just gives you a year-over-year growth chart for a couple of years, and I made it longer than just the most recent period because I wanted to show you that prior to the pandemic, our expectation was for Medicaid that Medicaid enrollment was flat, even declining. That's important because when the governor put his budget together last year, that's what we were expecting, declining enrollment. Obviously, as you can see to the right-hand side of that chart, we've had significant enrollment growth, 130,000 plus enrollees. That's a combination of people coming onto the program because of economic conditions. And it's also the fact that, as Anne said, we're getting this enhanced federal match. And one of the conditions of getting that enhanced federal match is we have to freeze redeterminations. So the annual redeterminations, which come up to see if you're still eligible for the program, have been postponed. So that, again, those two things are obviously driving enrollment growth. Just if you go to the bottom of the chart, bottom of the page, thanks, Anne. We just thought we'd show you where the enrollment growth has been by jurisdiction. The most significant growth has been in the Washington suburbs. Now, obviously, part of the problem with this kind of chart is you don't know what the starting point is. But it is, I think, worth pointing out that Montgomery and Prince George's Charles have had significantly larger enrollment as a percentage compared to other jurisdictions. So now back to Anne, who's going to talk a little bit about personnel trends.
Thanks. So yes, this next chart shows the vacancy rates as of the end of calendar 2020 in the department. Overall, the department shows vacancy rates of about 10.5%. This is mainly driven in higher vacancies in DDA facilities, in Medicaid, and then in Prevention and Health Promotion Administration. We wanted to highlight the fact that the department has been showing vacancy rates above 10% over the past few years. And while this recently declined slightly, and there is an appendix in the back of this document that provides some historical vacancy rates. But we just wanted to highlight the fact that the department's vacancy rate is still high at in the double digits at 10.5%. And this has shown how it has affected the state's response to the COVID-19 pandemic, as the department has had to divert a lot of employees to the pandemic response. And there's a lot of volunteer efforts supporting the department. And so we just wanted to highlight that at the end of calendar 2020, the vacancy rate remains above 10%. So then moving on to the issue discussion, our first issue that we'll go over is how, some of the trends and how the pandemic has impacted healthcare providers in the state, and then provide a description of some of the federal and state programs that have been made available to assist throughout this period. So Simon will begin with a discussion on Medicaid claim trends.
Thanks, Anne. I thought, obviously, we know that providers were hit, healthcare providers specifically were hit in the early months of the pandemic. Utilization was dropping. We don't have a full database that shows that drop for all providers, commercial, Medicare, and Medicaid, but we have a pretty good database, claims database for Medicaid. And we thought it'd be instructive to show you what happened in Medicaid, and perhaps as a proxy for what was happening elsewhere. What this chart does is just show quarter over quarter claims and spending and both percentage change. The percent change is more significant than the actual dollars spent, but you can see quite clearly that in the fourth quarter of fiscal 20, that's April, May, June, fiscal 20, the claims run through Medicaid fell fairly substantially, over 3%. If you go to the next slide, Anne, what this chart does is try to break down a little bit where the change was between quarter 3, which is January, February, March, and quarter 4. And we've done it for both fiscal 2019 and 2020, simply because there are, for example, in the inpatient outpatient area, there does tend to be a drop between the third quarter and the fourth quarter in any given fiscal year, simply because you'd expect that service delivery gets higher during the winter months, which are January, February, March, quarter 3. But you can also see that when you compare the claims in quarter 3 to quarter 4 in fiscal 2020, the drop in some areas is really very precipitous. Dental claims, for example, fell by over 70% in quarter 4 compared to quarter 3. Even inpatient outpatient spending was down significantly more than we would otherwise have expected. There were exceptions to this. Managed care, you can see there, it's a small increase in terms of the percent change in claims from third to fourth quarter, but it is a change, a positive change. And that's, of course, because managed care organizations get paid on a capitated basis. So as enrollment goes up, so do their payments go up. And I should also point out that there was also a change between in fiscal 20 that actually saw some pharmacy fee-for-service costs move into capitated rates. So that's a little bit of the increase, but really it's enrollment driven. If you go to the next slide, what this slide is trying to say is that if you go back, when we talked about that first slide, we showed how there was a rebound in spending, and there has been a rebound in claims. But I think what we're trying to show with this chart, in the Medicaid program, that rebound hasn't been universal across all provider types. What this chart shows you in blue is quarterly spending for fiscal 2020. The next bar, which is gray, is the fourth quarter. That's the quarter where the spending dropped. And then the last bar is the quarter 2 of 2021. So really trying to compare 2020 quarter 2 to 2021 quarter 2, seeing the blip in between. And what you can see from this chart is, again, because of enrollment growth, which we just talked about, MCO capitated spending continues to grow strongly. The one area that was really hit, dental, that is bouncing back. But it's still below, about 8% below the claims levels that we saw in the quarter 2 of 2020. So dental spending claims are rebounding, but not quite back up to the levels that we saw before. But the one area which is significantly impacted is long-term care. And that's almost exclusively because of a decline in claims for nursing homes. And that decline is frankly a reflection of the impact of COVID on nursing homes and the nursing home population, specifically in Medicaid, the elderly population. Elderly enrollment is lower now than it was a few months ago. And that most likely relates to the extent of COVID-related deaths in nursing homes in Maryland in the last 9 months. If you go to the next slide, what we're trying to do here, though, is say, okay, we know that providers were hit, but what kind of help has been available to providers from various different sources? And we're going to start, excuse me, with probably the largest area of relief for healthcare providers, and that was the Provider Relief Fund, which was established in CARES and administered at the federal level by the Health and Human Services Department. None of this funding goes through the state budget. In all, there's about $78 billion that has been provided to this fund. Some of it's general distribution, which means it's basically going to providers on the basis of lost revenues, and especially in Medicare and Medicaid, for example. Targeted distribution are what it describes there. There's specific funding that goes to certain hospitals, certain nursing homes, certain providers, based, for example, on the extent of COVID patients that they might treat. There's still, as of January, that we can, based on the data we're getting from the federal website, at least $24 billion of the $178 billion that is yet to be allocated. If you go to the next slide, $178 billion has been allocated, but as of January, only about $104.5 billion of that $178 billion has actually been reported as received. So there's still a significant amount of funding out there that could potentially go to help healthcare providers. In Maryland, as you can see on this slide, as of January 23rd, about $2 billion have been received by healthcare providers. If you go to the next slide, this is the what kind of providers have received the funding in Maryland. This was from December, slightly different dollar amount, but basically the proportion hasn't changed from January. Most of the funding goes to hospitals, and then a big chunk of it goes to nursing homes, with about 22% going to all the other providers in the state. Now, this shouldn't be surprising because a lot of the funding that's targeted and a lot of the funding based on actual revenues we would expect to go to hospitals and to nursing homes, because these are the facilities that have been most affected in terms of actually trying to treat COVID. The next slide just basically takes a different cut of this and looks at which providers have got what. And I think it's important to show this simply because some providers have got a significant amount of funding. At least 36 providers have gotten over $10 million, and they're all hospitals. And a couple of them, UMS and Hopkins, over $100 million each. But then when you look at the actual total in terms of the volume of support that's being given to providers, what you have here is over 90% of the providers have only received about 6% of the funding. So, you know, there has been significant support, but I'm sure that there are some providers out there that are still struggling because of the way that the funding is being distributed. Anne, back to you.
All right, so then I'll briefly go through a few other state actions that have provided some support to these healthcare providers overall. Like I mentioned before, the governor chose to move up the mandated 4% provider rate increase to January 1st of this year. The department also distributed some personal protective equipment. An example of this is that as of November 10th, DDA had reported that it had distributed 5 rounds of PPE to their licensed providers. There was also some testing support for nursing homes. There were strike teams and mobile medical units that were used to help nursing homes test their residents and staff. And then there was also some financial aid there to help with the testing costs early on in the pandemic. In terms of telehealth services, so obviously the providers were limited in some of the in-person services they could provide, especially during the stay-at-home order. So there was legislative action at the end of last session with that allowed the governor to expand Medicaid coverage of telehealth services, and then subsequent executive orders enacted this change so that Medicaid can now cover audio-only technology being used for telehealth services. I'll note here that these actions will end when the state of emergency ends, unless there is another executive action or legislation that would extend these changes beyond the COVID-19 pandemic. And there are multiple bills introduced this session that do propose extending some of these telehealth protocol changes or expansion. To shift over to more the actions impacting DDA providers and Medicaid waiver service providers, there was an appendix that was approved by the Centers for Medicare and Medicaid Services that allowed DDA providers to have some program flexibilities. And so this relates to telehealth, as one of the provisions was that DDA providers were authorized to provide services remotely or through telehealth. This appendix to their programs also provided some financial aid, as DDA was authorized to provide some retainer payments up to 30 days when the providers couldn't offer services due to the pandemic. In fiscal 2020, this amounted to about $18.4 million in retainer payments. And so while this appendix and program changes applied to DDA, it actually didn't apply to behavioral health providers. And so next, Andrew Garrison will give an update on the behavioral health provider payments early on in the pandemic.
Thanks, Anne. So as mentioned, the Appendix K waiver did not apply to the behavioral health providers. And what instead was in place was something that actually predates the pandemic. And that's this estimated payments. Because of the launch of the ASO early in calendar 2020, the department started giving out estimated payments to behavioral health providers based on fiscal 19 claims. Of course, about 2 and 3 months after that, the pandemic did hit and a lot of services were impacted throughout the state. And these estimated payments actually continued into August until the ASO was able to process the claims on a more live basis. But because a lot of those estimated payments occurred during the time of the pandemic when service utilization was much further down, what ended up happening is now the department is reporting a net overpayments to the providers. Right now, that number is estimated to be 163 million. And so while at the time it was able to provide a lot of steady and stable revenue to those providers, what is in practice ended up happening is that because services were down, they are now owing the department money. And so on the page here, we list a few concerns that we have from there, and we are working with the department to sort through some of these, and we'll be talking about this much more later in behavioral health analysis. But first off is that really sorting out the impact between different provider types within the behavioral health system. For instance, some providers might have had an easier transition to telehealth, and so their utilization impact might have been lower than different types of providers that were more intensive or more in-person, who might have had services drop much further down. And the delta between the utilization between calendar 20 and calendar 19 does impact the amount that a provider will ultimately end up owing the department. Further, the estimated payments were not set up to be a way to help with other costs incurred during the pandemic. So purchasing of additional personal protective equipment, while some of these providers may have had a surplus of funds relative to what they were actually providing at that moment, knowing that they would have to pay the department back because it was set up prior to the pandemic made a lot of them hesitant to spend those funds on some of those extra needs for providing care safely. And then also on the, just a little bit further down, we have 2 more items. One, there is going to be an administrative burden from this. What's happening now is the providers are reconciling their payments with the department. And so they're trying to come to an agreement upon what the actual number is for those overpayments. But that does take a lot of accounting and work that some of these smaller providers might not have the technical expertise and the ability to do. And then also ultimately, once the providers and the department agree upon a number, there will be this recoupment process of paying back the department. And that still might be happening while some of these providers are experiencing a downturn in services while we're still recovering or rebounding from the pandemic. And then we do have one more item that applied to both behavioral health and DDA providers that Anne will discuss.
Yes, thank you, Andrew. So this last source of financial aid for providers we'll talk about is from the Nonprofit Recovery Initiative grants that the Department of Housing and Community Development implemented. $10 million of this was earmarked for specifically licensed BHA and DDA providers. Of this, about $5 million went to DDA providers, 2.4 million went to BHA providers, but we did want to note that about $2 million of it went unallocated and then returned to the Department of Housing and Community Development to be allocated to other nonprofits applying for this grant. And DHCD had indicated that the reason for this undersubscribed funds was that they didn't receive $10 million in requests from BHA and DDA providers. So we just wanted to note this additional financial aid made available to them. So then moving on to our second issue in this overview, we wanted to highlight some of the COVID-19 data that shows that the state has experienced some pretty significant racial and ethnic health disparities in both the COVID-19 cases and rates of COVID-19 death in minority communities, and how this has emphasized existing disparities in health outcomes and social determinants of health. So this isn't specific to Maryland. This is a national trend. Early on in the pandemic, it was becoming more clear that the COVID-19 cases were disproportionately shown in minority communities, specifically in African American and Hispanic communities. The CDC had reported that of the states that report COVID-19 cases by race and ethnicity, that non-Hispanic African Americans showed a rate of cases that's 1.4 times higher than non-Hispanic whites. And then among Hispanic individuals, this group was showing a rate of cases that was 1.7 times higher than non-Hispanic whites nationally. And so looking at Maryland and a couple other nearby states, what this chart is showing is that each bar is the difference between the share of COVID cases for each specific race in the state, and then minus their share of the population. So an example is that while Hispanic Marylanders make up about 10% of the population, they were representing, as of January 22nd of this year, they were representing about 19% of the COVID-19 cases. So you're seeing a difference of 9% shown here. This is common in Delaware and Virginia of the states we looked at. And then you're also seeing a disproportionate shares of the COVID-19 cases being made up of non-Hispanic African American Marylanders. And so while the rate of COVID-19 cases is in Hispanic Marylanders is kind of similar to the other states, you are seeing that among the non-Hispanic African American population in Maryland, it is slightly more disproportionate than these other states. And then we showed the same data, but for COVID-19 cumulative deaths. And so anything above 0 means that a group is overrepresented in the state's count of COVID-19 deaths. Anything under means that they're showing less rates of COVID-19 deaths for the proportion of the population. And here you're seeing that in Maryland, the non-Hispanic African American population is about a little over 5% overrepresented in COVID-19 cumulative deaths. So this group is showing more severe impacts from COVID-19 compared to their share of the population. So then considering these trends that have been noticeable since the beginning of the pandemic, we wanted to look at the vaccine rollout and see if the initial vaccines administered was being administered equitably and proportionate to the state population. So as of January 22nd, you are seeing that it hasn't been proportional to population so far. As of a percentage of the state population, the African American population in Maryland is about 30%, whereas they're only making up about 15% of the vaccine doses administered. You are seeing that white Marylanders are being vaccinated at a higher rate compared to their share of the population. And then in terms of ethnicity, while Hispanic Marylanders make up 10% of the population, they're only making up about 4% of the doses administered. And so considering the unequal impacts of the public health pandemic on Black and Hispanic communities in Maryland, we wanted to emphasize the fact that the vaccine rollout hasn't been proportionate from the initial rollout. So this has emphasized the fact that there are existing racial and ethnic health disparities, both in health outcomes and in social determinants of health. The CDC has talked about how housing and a person's occupation plays a large role in, especially during the stay-at-home order, whether someone could adequately socially distance. And this has played a role in the higher rates of cases and severe outcomes. Or rather, there's also existing racial and ethnic health disparities in certain chronic conditions. And so we included a few measures on diabetes specifically, because that has been shown to create a higher likelihood that you'll have a severe outcome if you were to contract COVID-19. This chart specifically comes from the state's diabetes action plan that was published in June of this year. And even when certain social determinants of health like income are held constant, you are seeing at each income bracket that non-Hispanic Black adults are showing higher prevalence of diabetes than non-Hispanic white adults. And we especially wanted to emphasize these kinds of racial disparities. This only shows 1 year, but this trend is not new. The Department of Health has published decades of reports showing these kinds of racial and ethnic health disparities especially among non-Hispanic Black Marylanders. And so we just wanted to emphasize this as one of those factors that's contributing to the severity of the COVID-19 pandemic on minority communities. And then the Department of Health, especially with diabetes, has prioritized it as has prioritized diabetes prevention programs. This is one of the focuses of the public health or population health component of the state's total cost of care model. And then in the state diabetes action plan, there were also goals set that the department hopes to accomplish by 2024. This includes population health goals such as that 32% of Maryland adults will be of healthy weight. And we just emphasize the fact that these population health goals that were set don't include any measures specifically on lessening health, racial and ethnic health disparities, even as the diabetes prevention programs are prioritized and are show higher investment. Another more recent action to focus on diabetes prevention is that the HSCRC has awarded some funds through its regional partnership catalyst grants for diabetes programs. And so we just show this to talk about how the department has been focusing on diabetes prevention. However, it isn't, at least in terms of the goals it is set in the state diabetes action plan, it didn't specifically say to lessen the racial and ethnic health disparities that have been persistent and have been recorded over many reports. Other than that, there's one update on the cigarette restitution fund and then followed by some appendices with more detailed budget data. But with that, I'll conclude my presentation and I'd be happy to answer any questions.
Thank you very, very much. Are there any questions for our analysts? Sounds like there are none. Excellent. Thank you, all three of you, for your presentations. With that, we are going to hear from the Honorable Dennis Schrader, Acting Secretary of Health, and I believe you have a panel with you, sir, so we'll turn it over to you.
Madam Chair and Chairman Resnick, we have here, first I want to thank the analysts for an excellent report. We have no disagreements with their report. And I have with us today Deputy Secretary Jinlene Chan, who's our Public Health Secretary. I've also asked Acting Medicaid Director Tricia Roddy to be with us today, our CFO Jordan Butler, and Assistant Secretary Webster Yee. We're here to answer questions. And I might also say before we start, I think we all owe in the leadership a great debt of gratitude to the MDH workforce who was hung in there. Many of them were teleworking, but a lot of them were on the front lines working in our hospitals and in our local health departments. They have stood tall through this whole thing. So I want to honor them with recognition before we start. So we're here for questions, Madam Chair and Chair Resnick.
Thank you. With no concerns about the analyst report, I see a question from the Vice Chair of the Subcommittee, Delegate Valentino Smith.
Thank you, Madam Chair, and I recognize that we'll get into more specific budgets. I do have 4 general questions with respect to this budget. First, Mr. Secretary, thank you to you and all your staff. Look, this is unprecedented times and historic times, and I know you've been working day and night, and there's also had some blips and some places where we really have to ask, can we do better, or what can we learn? So first, on page 3 of the budget, it talks about the federal assistance to providers. And I think, you know, the whole intention here was to make sure we're not losing any historic providers in real important areas. And there's a lot of discussion about the providers that maintain the 8-507 beds, because we did get into, you know, some significant trouble with the Judiciary Committee and our availability to be able to handle the needs for substance abuse in the criminal justice system. So are there plans or intentions or anything in the relief packages to help? Because those providers clearly have lost and are at risk of maybe going out of business and not being there when we need them.
Yeah, we are planning to meet with Chair Resnick next week to have a discussion about this. We have, there's one or two providers that we have asked this question, particularly around 8507. We've given them answers, but the issue will continue to be discussed. So we're going to be having those discussions next week.
Thank you. We look forward to that. Again, with historic providers and the risk that we have because of the impact of them. In Prince George's County, we have a 67% African-American population. Your report just came out and showed significant disparate impacts to Black and Brown populations. One of our most historic providers to our children is Children's National Medical Center. And at the Board of Public Works, at the July meeting, they took one of the provider cuts. And I'm just asking, is there room now with respect to what's happening with the federal budget for you to revisit the importance of making sure that that provider is maintained with the same philosophy that you have for other providers in our state because the important role they play?
Yeah, I might ask Trish Roddy if she would address that first, and if there's any follow-up, we'll go from there.
Yeah, happy to do so, Dennis. So we have gotten letters and requests in on this very issue. We set DC hospitals rates differently than we do in Maryland. As you know, in Maryland, they're regulated by the Health Services Cost Review Commission, and Medicaid program participates in that process. And so we pay the rates set by HSCRC. DC hospitals have a different methodology. So the BPW cut that took place in July was extended for into the next fiscal year. Obviously, we do have additional federal matching dollars that are coming to our program. And we haven't at this point reached out to DBM to talk with them about this request, but we have noted it.
Well, thank you. And again, because of the significance of this provider for one of our largest minority populations of children, to be given the same philosophy, and you can do that through regulation. With respect to vaccine distribution, the charts were really reflective about the disproportionality. Is there consideration being given in distributing, not looking at distributing based on proportion of population, but rather based on proportion of infection rate, so that the jurisdictions, and obviously I represent Prince George's County, we've had significantly higher incidents related to a lot of the things that the analyst just reviewed with respect to historic disparity in being able to get to healthcare and suffering more comorbidities. But in terms of vaccine distribution, it to me doesn't seem to do by proportion of population, but should be by proportion of infection rate.
So as the way we're thinking about this, and you raise a very valid question because we're tracking that also. Our numbers show that we've got about 15% uptake within the African American community, and the similar half of what in the Hispanic community of what it should be. What we want to focus on, and we just set up an equity task force led by Brigadier General Burkhead. We had a massive rollout last week. We believe that we got to focus on the confidence in the vaccine, because the vaccine, if you look at, for example, the staff uptake within nursing homes, which is a very diverse population, we found about a 35% or less, or in that range, uptake amongst staff. Now that's starting to grow as we go back a second and third time, but we are pretty convinced that a big part of this problem is confidence in the vaccine. And so we're going to be focusing heavily on reducing the vaccine hesitancy.
Well, thank you, Mr. Secretary. Again, we'll have more time, but this is two different issues. One has to do with the actual distribution and the amount, which is what I'm suggesting is significantly needs to be recalculated for Prince George's County. And the second has to do with the resources that the county needs to effectuate the administration and to overcome vaccine hesitancy. So I hope, the next time we meet, we'll have a little bit more information from you on that. The final question, thank you, has to do with the Optimum Healthcare. Last time we visited and we talked to you and I asked these questions, the question was raised on whether or not the department is considering requiring the subcontractor to be changed. And, is it how do you, Insato and Credo, and who's the subcontractor that's not doing a good job here, but are you exacting penalties yet, or are you requiring penalties, or are you said you guys were going to look at it and decide whether you should have or force a change in the subcontractor? What's the evolution now?
Yeah, so let me see if I can briefly give you where we are on that. We have issued penalties of $80,000 a month for the primary contractor over a 3-month period, and we're continuing to evaluate that. We are making progress with Insato. Our concern is that anytime you change a system, we've stabilized the situation. Given where we are, we would not want to go through another change so soon that has the potential for making it very difficult for the providers. We are putting out $30 to $35 million a week, which is the historical payments that have gone out. But there are issues with certain organizations with their claims, and we're working closely with them. They just had a release this past week, which is going to make several improvements, and we're going to be making releases over the next 3 or 4 months. So we're giving them every opportunity to correct. They had a horrendous start back in January a year ago. They were able to stabilize it and get the system up and running at the end of July. We've been making payments on a regular basis since August, but the job's not done yet.
Thank you, Mr. Secretary. I know you came in the last hearing, you stated, your commitment and how hard you had worked and how far you had tried to bring this along, but it does still seem to be months and months and months of providers not being able to get the information they need to track their claims history, and the subcontractor has been given a lot of time to do better and isn't. So with that, Madam Chair, I appreciate you giving me the opportunity, Mr. Chair, to start these general questions and look forward to when we move into the individual budgets.
Thank you. Thank you. We have Senator Eckert has questions.
Thank you very much, Madam Chair, and to our Acting Secretary Schrader and to our Assistant Secretary Yee. Thank you so much. Our health departments, and I tell you all this daily, but you all done a great job in unprecedented times. So we appreciate that. And I guess I just want to follow up because we talked a lot about making sure that our traditional indigenous providers are whole and we don't lose them. And we've had a number on the Eastern Shore, as you well know, who have had such difficulty because they've declared to have overpayments, and just getting the information they need to get those claims validated and processed and reconciled. So I just want to make sure that there's enough action and enough change from your perspective that we are going to be able to make sure that in the end game, these folks are going to be there because we need them. As you know, with the rising new population of anxiety, depression that's coming up either through our families with schooling at home and getting back to school, or the increased substance use and abuse that's going on, we're going to need all our behavioral health providers. So are you assured that the changes within the ASO are going to ultimately get these folks the resources they need to continue to stay in business at a critical time.
Yes, well, we obviously are monitoring this on a every week basis. The data I've seen recently suggests that there are, continuous improvements. It's never as fast as I would like, but as long as I continue to see the improvements, we're gaining confidence. We're also being very careful on the reconciliation. We've seen steady progress there, and we've seen a lot of improvements since we put in the JCR. We've extended the period for reconciliation and broken it into chunks, and I'm feeling a lot better that we're moving in the right direction. But until it's done, I'm not going to be satisfied.
Yeah, thank you very much. And a lot of times we see it's the mechanical things, you request data, you give the data, you don't get it, you can't get a person on the phone, you don't get a response on an email. It's some of those same kinds of things, unfortunately, that are happening from my perspective with signing up for vaccines. Where do I sign up? How many times do I sign up? How do we get a clear process with reasonable expectations, a certain element of predictability, and a clear message on how to do things so that everybody's not left to their own interpretation of how to proceed on this? I think that kind of is useful at a time when we're all a little bit high anxiety, and bouncing is the word I like to use because of so many changes. How do we get people to be calm and deliberate and use everybody's best thinking to navigate, all of us navigate this system? So I'm just hoping that you will take a look at that and are taking measures to further refine that. Thank you.
Absolutely.
Thank you, Madam Chair.
Thank you, Senator. Are there other questions for the subcommittees? Okay, well, I do have a question. And first, let me say, I know that a lot of the deeper dive work we'll do, as I think someone stated, when we get into the individual budgets. And I certainly want to join you in applauding the team that's been working throughout this pandemic, dealing with multiple issues simultaneously. It's an unenviable task that you have in front of you, but we must do what we must do in our role. And so I just kind of wanted to go back. Ms. Wagner talked to us a little bit about the federal fund expenditures. And it occurs that there is a portion of the funds, and I think she mentioned 500 million or so that has not been expended, or that at least is not reflected in the budget. And so it would be helpful for us to hear what your process is and what plans you might have for sharing with us how you plan to expend or distribute those resources that haven't yet been spent.
Madam Chair, I'm going to ask our CFO, Jordan Butler, to address that question. Jordan.
Hi there. Thank you for your question. So right now, there's a lot to be said around this issue, because there's a lot of federal money that came down right after last session let out. And so our FY 2020 and FY 2021 budgets didn't anticipate all of this additional federal funding that we would be receiving for the response. The federal funding that we have for FY 21 is not currently reflected in our budget at this point. And that's for two good reasons. The first is that it's been a challenge for my office to move and pivot throughout the course of the fiscal year. And it's actually a very good problem to have. It's because we've had so many different federal funding sources come down the pike, and the rules around the federal funds have changed on a near weekly basis. And so while we are planning for the COVID response and spending money appropriately, we're also juggling what federal fund sources we can best use. And those federal funds range from grants from the CDC to the CARES Act's coronavirus relief funds, to FEMA's public assistance disaster relief funds. And those federal funding sources are in constant flux. Some of them are for vaccination, some of them are for testing, some of them are for anything directly or indirectly tied to the pandemic. And so since July, when the fiscal year began, we've been piecing together all of these moving pieces in the best way that we can while we've been implementing our COVID response. And it's been in partnership with the Department of Budget and Management and our other state agency partners in the state to get as much certainty as we can around what we're spending our money on and what are the best dollars to support those activities. Right now, we are working with DBM on strategizing the best way to reflect those funds in MDH's budget. There are considerations for a supplemental budget that may be dropping soon. And if that doesn't come to pass, then we'll be doing a budget amendment shortly. But I can tell you, because we're now into February, which is month 8 or 7 of the fiscal year, all of these funds that we have, we're getting to the point where we don't have enough authority to spend those funds. And so the rubber is about to hit the road, and we do need to reflect these budgets, these appropriations, in order for us to continue our spending.
Thank you for that. And we know that there have been some funds that have gone directly to local jurisdictions and local health departments. Some of the funds that we've received have a lot of strings attached and can only be spent for specific purposes. Just want to invite you and encourage you to keep us posted as you determine uses for those sort of undesignated or non-specified uses for some of the funds that you have coming. Obviously, we're deeply concerned about the needs that we hear from our constituencies, and the more we are aware of what's happening, the better we can communicate with our stakeholders, who are our colleagues in the General Assembly and the communities that we serve. The other thing I wanted to mention, just to put it on your radar, something that we'll be looking at and have been talking about through the joint COVID work group over the interim and through our work on equity and inclusion. We'll also be hoping that as you secure products or services, wherever possible, to take advantage of local, small, minority, and women-owned businesses here in the state of Maryland. We certainly want to encourage that, and it's a multiplying effect when we're able to do that. And so just wanted to put that on your radar screen as well. I think the other items that I have on my list we'll be able to talk about. We'll be spending a lot of time together over the next couple of months as we go through the individual budgets. I want to open it up again to members to see if anyone has a question or comment for our panel. Okay, seeing none, Mr. Chair, do you have any remarks before we close?
Thank you, Madam Chair. I just want to remind the members of my subcommittee that we do have a very, very brief one bill voting session at 3 p.m. You all should have that information. And so I look forward to seeing you all there.
The hardworking House Subcommittee is going to have a voting session. Colleagues, we will reconvene on Friday. I think that is the next time our subcommittee is together on Friday. We'll be together tomorrow in other capacities. But let me say thank you again to the analysts who presented today and who are working nonstop. Mr. Secretary, I know your staff is working hard. Ours is too. And so we want to thank them and the members. Thank you for your presentations today, and we'll see you again